Eu vejo para TJP. Ah, TJP. Si JB. Ano? Oh, okay na pa. So, good afternoon, doctors. I am Dr. David Arroyo. I'm here to report about abnormalities of cardiac conduction and rhythm. So, these are my objectives. So, electrocardiography is an electrocardiogram is a graphic recording of electrical potentials generated by the heart. It detects arrhythmia, conduction disturbances, myocardial ischemia, life-threatening metabolic disturbances such as hyperkalemia, increased susceptibility to sudden cardiac arrest. So, here's a normal ECG reading. The P wave is a small upward deflection that represents depolarization of the atria. The PR interval is the time between the beginning of P wave and beginning of the QRX complex. Um, ay, tama. The PR segment is the flat line between the end of the P wave and the start of the QRS complex. It represents the time between atrial and ventricular activation. The QRS, uh, the QRS complex is a distinct waveform that represents the rapid depolarization of the ventricles. This ST segment is a horizontal line that represents the interval between ventricular depolarization and repolarization. The QT interval is the time from the start of the QRS complex to the end of the T wave and represents the total time for ventricular depolarization and repolarization. So this slide shows the cardiac cycle, and below this is the ECG representation for each section of the cardiac cycle. So we have here an example of normal sinus rhythm. The rate is 60 to 100. Each P wave is followed by a QRS complex, and each QRX complex is preceded by a P wave. The distance between R and R intervals is equal. So for this ECG strip, we have sinus arrhythmia, still within 60 to 100 beats per minute. The variation of P intervals or RR interval is more than 120 millisecond. P waves, PR interval, and QRX complex is normal. So we see this ECG strip. We first determine the rate. So it's more than 100. Um, the rhythm is regular. Um, there are present P waves, then the QRS is normal. So we have sinus tachycardia. With normal P wave before every QRS complex and PR interval, it is caused by acceleration of SA node discharge secondary to sympathetic stimulation, can be normal response to or a compensatory mechanism. It is associated with acute MI in 30 to 40% of patients. So for the management, we can correct the underlying cause of increased sympathetic stimulation. Possible causes are hypovolemia, infection, hypoxia, MI, CHF. We can also give supplemental oxygen and beta blockers, except in those prone to bronchospasm and has impaired cardiac function. So for this ECG step, um, it has a 100 to 160 to 180 beats per minute. Okay. So what could it be? Supraventricular tachycardia. So it's triggered above the AV node. Symptoms are lightheadedness, dizziness, fatigue, chest discomfort, and dyspnea, overt syncope, or delirium. This occurs even with no heart disease in younger individuals. So for the management, if hemodynamically stable, we can do carotid massage or Valsalva maneuver. So for pharmacologic management, we can use adenosine 6 milligram rapid IV push followed by normoxilin flush, and if needed, second dose of 12 milligrams. For the management using electrical cardioversion, these are patients who are unresponsive to drug therapy, hemodynamic instability. We can do synchronized cardioversion. So for the next strip, we have a rate of around 250 to 400 beats per minute, regular ventricular rate, and there are P waves are absent, parang flutter waves, normal QRS complex. So this is an example of ATL flutter. It's an organized ATL rhythm of 250 to 350 beats per minute with varying degrees of AV block. Rapid P wave create a sawtooth appearance called flutter wave. Uh, for the management, we can do, if patients are hemodynamically unstable, we can do cardioversion with 50 joules by using monobasic. For hemodynamically stable patient, overdrive pacing uses transesophageal or atrial electrodes. Um, so we can also use we can for hemodynamically stable patient, the primary goal is to control ventricular rate to avoid severe hemodynamic instability. If if ventricular rate is more than 300 beats per minute, the end is most likely the mechanism. So we can give procainamide and other drugs such as amiodarone, diltiazem, verapamil. So for the next step, so the APL rate cannot be measured. Ventricular rate is variable. P waves are absent. Uh, PR interval cannot be determined, and the QRS complex is normal. So what could it be the reading? This is a atrial fibrillation. So it occurs when multiple areas of atria continuously depolarize and contract in a disorganized manner. In a disorganized manner. Irregular electrical input of the AV node result in sporadic AV nodal conjunction. Thus, an irregular ventricular contraction is the most common sustained cardiac dysrhythmia. For the management, most new onset AFib spontaneously convert to sinus rhythm within 24 to 48 hours. The goal is to have ventricular rate control and electrical or pharmacologic cardioversion using beta blockers, calcium channel blockers, and digoxin, uh, and amiodarone. So for the most effective method of cardioversion to sinus rhythm is yung cardioversion. Indicated to those with coexisting symptoms of heart failure, angina, and hemodynamic instability. In hemodynamically unstable patients, we can use 100 to 200 joules using basic defibrillator. So for the next step, uh, the rhythm is irregular. The P waves with different does have different morphology. Uh, The QRS complex is normal. So what could be this? So we have premature ventricular contraction. So in ECG, premature wide QRS complex, no preceding T wave, ST segment and T wave deflection opposite to the QRS deflection. Compensatory pause, there's compensatory pause before the next sinus speed. This can occur as short episodes with spontaneous termination or a sustained period of hegemony or trigemony. Symptoms include palpitations and syncope. So for the management, treat when frequent and polymorphic and occurs in runs of three or more exhibit on T phenomenon. Elimination of iatrogenic mechanical irritation of the heart, such as intracardiac catheter, and you can also use beta blocker. So for the next ECG strip, so tachycardic rate, uh, the onset tachycardia, abrupt and regular, T waves are present, um, QRS complex is Y. So, anong reading to? Yan, ventricular tachycardia. So, monomorphic ventricular tachycardia, three or more consecutive ventricular premature beats occur at a heart rate of more than 120 beats per minute, usually 150 to 200 beats per minute. It can be non-sustained, paroxysmal, or sustained rhythm. Um, Regular rhythm with wide QRS and no discernible T waves. It's commonly seen in acute myocardial infarction, inflammatory or infectious disease of the heart, and digitalis toxicity. For unstable patients, we can do cardioversion at 100 joules monophasic and increase by increments of 50 to 100 as necessary. For stable patients, we can use amiodarone 150 milligram over 10 minutes, and alternate drugs of procainamide, sotalol, and lidocaine. So, yes. Saan po? Okay. Ano po? Sorry. Sorry. Oh, okay. Ah, monophasic rice. Monomorphic po yung first one. Nasa taas. Yung, sa baba. Polymorphic po. Mas stable. Yung nasa taas. Ay, basta sa baba. Yeah. Ah, so 2.2 grams. In 24 hours. Oh, ay, di ba? Yun ang baso ko. Mag-February. Ano daw, mag-February. Ay, ano? So the rate is chaotic, uncountable, rhythm is irregular, P waves are absent, QRS complex, and no normal QRS complex are noted. So this is ventricular fibrillation. It's the most common cause of sudden cardiac death, and the most uh, underlying is it occurs in less patients receiving beta blockers, ACE inhibitors, and statins. So for the management, CPR must be initiated immediately. Defibrillation is the only effective method for conversion into a rhythm-generating cardiac output. It depolarizes all cardiac cells at once. Ideally, a single pacemaker focus will then restore the myocardial synchrony. So for the defibrillation, we're using biphasic 120 to 200 joules or monophasic 360 joules. Then we give epinephrine 1 milligram IV every 3 to 5 minutes. Can also give amiodarone and lidocaine. So for this ECG strip, we have less than 60 beats per minute. The rhythm is regular. There is P wave present. Um, the QRS is normal. So we have sinus bradycardia. The heart is less than 60 beats per minute, may be normal in trained athletes or during sleep. Abnormal in inability to increase heart rate during exercise. Symptomatic bradycardia, syncope, dizziness, and chest pain. Um, yeah. So for the management, for symptomatic patients, no treatment required. Monitor for worsening bradycardia and hemodynamic deterioration. For mildly symptomatic patients, any potential contributing factors such as excessive to vagal tone or drugs should be eliminated. For severe symptomatic patients who have chest pain or syncope, immediate transcutaneous or transvenous spacing, atropine is of 0.5 milligram IV every 3 to 5 minutes, the maximum of 3 milligrams. Or small doses of atropine, 0.5 milligram IV can cause further slowing of heart rate. If cardiac pacing is delayed, start epinephrine or dopamine. So these are my references. Thank you po. Trip, trip one. Trip. 0.5 po. Ang bilik. Okay. Pang 2020. 2024 po. Okay. 0.5. Sa, ito po yung sa 2020 po. Hindi ko po nakuha. 1 milligram. Max po 3 milligram. Apa, 3 milligrams. Ayan. Okay. Next. Next slide. Yes, no.
Good afternoon, Arroyo, Valle, in your anesthesia resident. I will be reporting case management of obese patients. My objectives for today, to provide an overview on obesity, its classification, pathophysiology, treatment, and effects on different organ systems. To examine anesthetic considerations on obese patients undergoing surgery. Now, case, as for example, patient CD, 48-year-old female, diagnosis of sepsis secondary to skin and subcutaneous infection, secondary to human guide, AKI intrinsic, probably secondary to infection. Surgical plan was for debridement at the left shoulder. Anesthesia plan was general anesthesia, the regional muscle. For the past medical history, the patient is hypertensive, time non-compliant, no other comorbids. Um, 10 pack year smoker, occasional alcoholic drinker, no allergies, no illicit drug use. And previous anesthetic experience wound debridement under JLMA as well. For the general survey, patient was conscious, coherent, and not in distress, and the vital signs were as follows. The patient's weight is 90 kilograms, and the ideal body weight is 55 kilograms. BMI of 35.16, uh, allowable of 0. For the airway evaluation, malampati 1, perimeter distance of 5 to 6 centimeters, and complete no bruise with no dentures. Good neck mobility. For the PE, pertinent, slightly big, non-healing at the left anterior shoulder, early to superior leg discharge, and grade 2 by PWD. Here are the results. Yes po. Previous patient po siya last September. Um, okay. For the assessment, sepsis secondary to skin and subcutaneous infection. Same, wala po. For this patient, wala pong stop bang na ginawa. And that's one of the considerations po, dapat may stop bang for this patient. Example lang po siya. Um, yes po. Um, sino makakasagot? Sino may alam ng stop bang question niya? Sige, just to repeat, ito yung sabi ni Dr. Nopal, yung stop bang questionnaire. So for the S, one of the questions that some of the questions have been asked the patient. So the patient snores loudly, dinig pa siya, closed doors, uh, they're talking voice. Kung during their waking hours, where they feel tired or sleeping or somnolence during the time. And then, sa mga kasama niyo sa bahay, when the patient is sleeping, if we are able to observe that the patient stops breathing or choking or gasping while they're sleeping, then for if the patient is being treated for high blood pressure or if the patient is hypertensive, then for if the patient's BMI is more than 35, the patient is more than 50 years old, the next circumference is more than 17 inches, or around 40, around 43 centimeters. And if that's the patient is male, 7, but the female, 16 inches. And then the patient. And then for the interpretation, 0 to 2, the risk, 3 to 4 intermediate, and 5 to 8 high risk for start 1. Or when the patient is more high risk, please 2 sa stop plus 1 of 2 sa family. I see 2 sa senior lower right. Meron naman for the pediatrics, so very risk questions. So if the patient snores more than half the time, snores loudly, has trouble breathing or struggle to breathe, ever stops breathing during the night, wakes up feeling under pressure. For the interpretation, is for is for PRE. PRE is perioperative respiratory adverse event. 3 or higher is for PRE. Okay, so going back to, balik muna ako sa first half ng report. But that's for OSA, obstructive sleep apnea. Okay, so again, for my recommendations, obesity is currently the 5th most important risk factor for disease worldwide. It's a condition with excess body fat to the extent that health and well-being are adversely affected. Normally high amount of adipose tissue compared with lean muscle mass. So more than 20% or 20% over ideal body weight. And diabetes, cardiovascular disease, obstructive sleep apnea, non-alcoholic fatty liver disease, osteoarthritis, and some types of cancer. These are the leading causes of morbidity and mortality in the obese population. Now for the indices, we can make use for ideal body weight. It's the weight associated with the lowest mortality rate for a given height and gender can be estimated using the Broca index. So yan yung this is what we usually use in computation. So height centimeters minus x. And if the patient is an adult male, the x is 100. For adult female, x is 105. Next is predicted body weight. Similar concept with ideal body weight, commonly used in medical literature. So for males, this is the formula. For females, so you just have to substitute the with the values of the patient. Next is lean body weight. Total body weight minus the adipose tissue. It is a combination of body cell mass, extracellular water, and non-fat connective tissue. Approximates 80 and 70% of males and females respectively. And if you try computing yung body weight, it's almost the same result with ideal body weight. Almost. You try and do. Body mass index, which we also use all the time, like use in clinical practice to estimate the degree of obesity. So body weight in kilograms divided by height squared meter squared. Now, obesity is defined as having a BMI of 30 kilogram per meter squared or more. Can be further classified according to systemic disease risk, waist circumference correlates with abdominal fat and this is an independent risk predictor of disease. Okay, ito naman yung if the patient is lesion. Okay, so obesity based on anatomic distribution of body fat. And android obesity, also known as the central obesity, adipose tissue is located predominantly in the upper body or truncal distribution. It's associated with increased oxygen consumption and increased incidence of cardiovascular disease. Whereas in gynecoid obesity, yung sa letter B, yung sa female, peripheral obesity, adipose tissue located predominantly in the hips, buttocks, and thighs. And fat is less metabolically active, so is less closely associated with cardiovascular disease. Adverse health implications for multiple organ systems can be due to too much energy or food intake or sedentary lifestyle resulting to positive energy balance, lipid overload, increased visceral fats resulting in insulin resistance, inflammation, increased cardiometabolic risk, and impaired insulin secretion. Higher risk of type 2 diabetes mellitus, and increased risk of cardiovascular disease. For the respiratory system, fat accumulation in the thorax and abdomen decreases chest wall and lung compliance. Decreased lung compliance partially because of increased pulmonary blood volume related to an overall increase in blood volume. So decreased FRC, functional residual capacity, respiratory support, vital capacity, and total lung capacity. There's exchange residual volume and closing capacity. Closing capacity is the volume in which the small airways begin to close. Decreases in FRC and ERP is common abnormalities in pulmonary function in these patients. ERP is the most sensitive indicator of the effect of obesity on pulmonary function. FRC declines exponentially with increasing BMI and may decrease to the point that small airway closure occurs, leading to lung volumes below closing capacity in the course of ventilation, leading to ventilation perfusion mismatch, right to left shunting, and ventricular syndrome. These are the following effects of obesity, positioning, and anesthesia on lung volumes. Anesthesia and supine positioning worsen this situation such that up to a 50% reduction in FRC person the is anesthetized patient compared with 20% in the non-obese individual. So as in the picture, but in decrease yung ERB, but yung BC, biocapacity, FRC, and total lung capacity. And the decrease in the FRC impairs the ability of these patients to tolerate periods of apnea during the regular endoscopy for intubation. These individuals likely to experience oxygen desaturation following induction, despite adequate oxygenation. Now, what we were talking about earlier, obstructive sleep apnea, it's a periodic partial or complete obstruction of the upper airway during sleep. And airway obstruction produced by excess soft tissue. There is cessation of breathing for longer than 10 seconds during sleep. It results to hypoxemia, hypercapnia, pulmonary hypertension, systemic vasoconstriction, and secondary polycythemia from recurrent illness. And there is increased risk of ischemic heart disease and cerebrovascular disease. The gold standard for determining the patient has obstructive sleep apnea is the OPS or the overnight polysomnography. Screening questionnaires to identify patient high risk for obesity. And you can make use of these stop bank and SEPU. So the symptoms include snoring, frequent arousal during sleep, and daytime sleepiness. There are impaired concentration, memory problems, and morning headaches. Moving on to the cardiovascular system. in obese patients, total blood volume is increased. Most of the volume is distributed in adipose tissue, around 2 to 3 ml per 100 grams of tissue. Renal and splanchnic blood groups are increased, and the cardiac output, it increases with increasing weight as much as 20 to 30 ml per kilogram of fixed body fat. This is because of the ventricular dilation and increase in stroke volume. Total blood volume is increased in the obese individual. This results to increased left ventricular wall stress leading to hypertrophy, reduced compliance, and impairment of left ventricular rhythm with elevated left ventricular diastolic pressure. When the left ventricular wall thickening fails to keep pace with dilation, systolic dysfunction, and eventual biventricular failure result. Frequent ECG findings in morbidly obese patient can include low QRS voltage, LDH, left atrial enlargement, and T-wave flattening, and the inferior lateral leads. Many obese patients, they have mild to moderate hypertension, and every 10 kilograms weight gain can increase systolic arterial pressure by around 3 to 4 millimeter mercury, and 2 millimeter mercury increase in the systolic arterial pressure. And RAS plays a major role in the hypertension and obesity because of increased levels of angiotensinogen, aldosterone, and angiotensin converting enzyme. They have normal to increased level of sympathetic nervous system activity, disposing to insulin resistance, dyslipidemia, hypertension. And then if the patient has hypertension and diabetes, increase results in left ventricular wall thickening and increase the likelihood of cardiac failure. And obese patients have higher levels of fibrinogen, factor 7, factor 8, von Willebrand factor, and plasminogen activator inhibitor, and also the hypercoagulability state. For the gastrointestinal system, the gastric volume and acidity, they are increased, hepatic function is altered, and drug metabolism is adversely affected. There is high prevalence of non-alcoholic fatty liver disease, non-alcoholic steatohepatitis, focal necrosis, and cirrhosis. There are abnormal liver function tests in up to a third of obese patients. Increase abdominal mass, leading to antral distension, gas and release, and decrease in pH with parietal cell secretion. Also with the gastric. For the endocrine system, there's a high prevalence of type 2 TM in obese patients. They have resistance of peripheral adipose tissue to insulin. Risk of developing TM increases by 25% for every 1 kilogram meter squared increase in BMI above 22. They have hyperglycemia, insulin resistance, and in type 2 TM patients would increase risk for wound infections and MI. And exogenous insulin, it's usually required, may be required perioperatively to oppose the catabolic response to surgery. So clinical hypothyroidism can also occur in about 25% of morbidly obese patients. And metabolic syndrome is also known as your syndrome X, insulin resistance syndrome, if they have at least 3 obese people. Now, for the renal system, obesity associated with glomerular hyperfiltration as evidenced by increased renal blood flow, increased glomerular filtration rate. Excessive weight gain increases renal tubular resorption and impairs natriuresis through activation of the sympathetic and RAS, as well as physical compression of the kidney. And in prolonged obesity, may result to loss of nephron function, increasing risk of renal disease. Now, for the aesthetic considerations of obesity, comprehensive preoperative evaluation is critical. We should be able to identify and address possible multi-system vulnerabilities and develop individualized perioperative care plans. For the history PE, should focus on the history taking and physical examination and the airway evaluation, cardiopulmonary, metabolic, and hematologic system. In obese patients, obesity is considered a risk factor for difficult mass ventilation and for airway management. So overall, the magnitude of AMI does not significantly reduce the difficulty of laryngoscopy. Difficulty in most studies correlate instead with age, if the patient is male, uh, temporomandibular joint pathology, and Malampati classes 3 and 4, patients with obstructive sleep apnea and normal upper T. And then next circumference is the biggest predictor for difficult intubation in morbidly obese patients. Some anatomic changes in obese patients. They have limited movement of the atlantoaxial joint and cervical spine, have excessive tissue folds in the mouth and pharynx, have short, thick neck, thick submental fat pad, suprasternal, external, and posterior cervical pad, and large breasts in peoples. Evidence of obstructive sleep apnea, difficult airway management, and increased perioperative pulmonary complications. And this is also why we have to, in obese patients, we have to determine if the patient is high risk for obstructive sleep apnea or if the patient is diagnosed for us. And if using CPAP at home, the patient should be instructed to bring it with them to the hospital as it may be needed post-operatively. For equipment and monitoring, usually the regular operating room tables have maximum weight limit of approximately 200 kilograms. Strapping these patients to the OR table with malleable bean bags can help keeping them from. So properly sized blood pressure cuff and dislocation are important. Cuffs with bladders should encircle a minimum of 75% of the upper arm circumference or preferably the entire arm. If the cuff is too small, the PP can be also elevated. And other standard monitors should be present as well, pulse ox, cardiac monitor, and code, thermometer. Sometimes, if invasive monitoring is warranted, you can make use of that as well. Now, for the positioning, uh, we can use the ramp position. It improves the view compared to the standard sniffing position, especially during the endoscopy. So elevating the obese patient's upper body, we can achieve this by stacking towels or folded blankets under the shoulders and to compensate for the exaggerated flex position of the posterior cervical pad. So in positioning, head up position it provides longest sleep apnea period during induction of anesthesia. It's more favorable than supine. So can be recommended that when inducing obese patients, we can use head up position. Excuse me. Ano po? Ano po? Ano yung target? Kailangan naka-align yung sternum yung sa uh, yung sternum and the tragus it should be aligned. Yes, Doc. For better visualization and laryngoscopy. Hindi. Masyadong mataas yung sternum. Dapat mas mababa ng konti. Okay, so imagine mo lang mas mababa ng dapat yung sa Mr. Delivery. Sorry po. Now, for the choice of anesthesia, uh, may be technically difficult in obese patients since landmarks are skewed with excess adipose tissue when it comes to regional anesthesia. So risk of a pit block is about 1.5 times higher in patients with a BMI of more than 30 and 20% less local anesthetic for spinal or epidural than non-obese patients. Epidural and spinal anesthesia preferably in sitting position. Um, Now, some advantages over general anesthesia. Airway intubation difficulties are avoided. Risk of gastric aspiration is reduced. Lesser post-operative respiratory complications. Patient is awake, can do, and early ambulation as compared to GA. And if GA is warranted, ideally, at least two anesthesiologists should be present. Some problems with GA can include maintaining a proper fitting tight mask, maintaining the airway, regurgitation aspiration problems, and some patients have limited range of head and neck mobility, and anticipated difficult airway. Difficult airway carton equipment must be prepared and immediately available when inducing these patients. For airway management, in pre-oxygenation, adequate pre-oxygenation is critically important in these kind of patients, since these patients have decreased efforts in higher oxygen consumption. Preoperative use of NIPTV or application of CPAP during induction can also delay peri-induction rate. Sometimes, owing fiber optic intubation using topical or regional anesthesia can be is more recommended sometimes. And then our other airway devices, intubation with the help of stylet, video laryngoscopes and LMP. Sedative hypnotic medications should be minimized. Can make use of dexmedetomidine during omic intubation to provide adequate anxiolysis and analgesia with respiratory depression. Yes, ma'am. Yes, ko. When it comes to the time for reoxygenation, I wasn't able to see any specific how many minutes is adequate. If you compare it to our usual 3 to 5, um, but use of positive pressure ventilation and yung CPAP, it helps with reoxygenation. Sorry, can you repeat that? Dito, there should be uh, peak when it comes to ventilating. Yun ba? In manual ventilation po ma'am, yung even manual. May titira pa ring pressure ma'am when it comes to manual ventilation. Tanda. So metal capacity. Vital capacity breaths ma'am. Four po. Eight po. Three. Yes, ma'am. 3 minutes. So, when it comes to drug dosing, we should consider the volume of distribution for administrating the loading dose and the clearance for the maintenance dose. A drug that is mainly distributed to in tissues should have the loading dose calculated based on mean body weight. And if the drug is equally distributed between adipose and lean tissues, dosing should be calculated based on total body weight. For the most of the drugs that we compute using the lean body weight, except for some. Succinylcholine, dexmedetomidine, histamine, uh, and maintenance dose for propofol. For, yung sa propofol po, yung maintenance po, yung induction dose, we make use of the lean body weight po. Yes. Ano po ma'am? Which among the drugs we use? Um, yan, yung lahat po, except yung, ito po ma'am, yung succinylcholine, dexmedetomidine, and maintenance doses for propofol. The lead body weight po ma'am. Hindi ko ma-zoom. So for the mechanical ventilation, tidal volume recommended 6 to 8 milligram per ml per kilogram. No specific predicted body weight po. Predicted body weight po. And then no specific ventilatory mode found significantly better for oxygenation and carbon dioxide clearance in obese patients. PP is the only ventilatory parameter consistently shown to improve respiratory function in these patients. We may make use of recruitment maneuvers plus PEEP as most effective technique to prevent post-operative atelectasis. Targets the opening and passing of small airway units, improving the ventilation perfusion matching. Uh, there's less of atelectasis and improved oxygenation, shorter stay in the back, and decreased post-operative pulmonary complications after laparoscopic surgery. Yun po yung paano ba? We can make aside from making use of deep up to around 10 centimeters water, in recruitment maneuver we can give by vital capacity. Papataasin when ventilating you can up to 40 centimeter water to breathe the the alveoli. Yung when ventilating po ma'am, in you do sustained inflation around 10 seconds, 30 at around 10, 30 to 40 pressure CL water. Sustained pressure of around 30 to 40 centimeter water, around 10 to 30 seconds. Sustained. Water. For emergence and extubation, it's recommended the patient is fully awake and alert and have recovered from the depressant effects of anesthetics. Also recommended, patient is in semi-recumbent position and recovered in the sitting position. Supplemental oxygen should be given after extubation observe for at least 5 minutes after exhibition before transporting the patient from the operating room. And then at the back should should be should have continued the oxygen supplementation. In postoperative management, these patients have increased risk of atelectasis. Initiation of CPAP or BiPAP, it includes oxygenation, but does not facilitate carbon dioxide elimination. Other useful adjuncts to avoid postoperative hypotension and atelectasis, there should be adequate analgesia, properly fitted elastic binder for abdominal support, early ambulation, deep breathing exercise, and incentive spirometry. To provide adequate anesthesia, also facilitate early mobilization. We can make use of multimodal analgesics, regional anesthesia, and anesthesia techniques over general anesthesia. Early mobilization, supplemental oxygen, and elevation of the head. Here are my references. Um, bradycardia and barotrauma. And hypotension. Okay, ma'am. Okay po, ma'am. Long recruitment maneuvers. Thank you. Ito ba yung sa'yo? Yan. Saan yun? Saan yung mic? Good afternoon, everyone. I am Michael John Dumadag, first year anesthesia resident, and I will be reporting on a journal article. So for my objectives, it is to first appraise the journal of the anesthetic care for obese patients and to incorporate and apply the findings of the journal article in relation to the patient. For the clinical scenario, again, we have DC, a 48-year-old female, history of skin infection, secondary to human bite, diagnosis of sepsis secondary to skin and subcutaneous infection. For repeat wound debridement of left shoulder, has a past medical history of hypertension, 10-year smoker, and occasional alcoholic beverage drinker, with the pertinent and a salient feature of 90 kilograms and a BMI of 35.6 kilograms meter square. Anesthetic plan, GA element. For the clinical question, here we have, I phrased it in such a way that will address the statistical probability of developing perioperative complications based on the classification of obesity. So the question I formulated is, in the anesthesiologic care of obese patients, is a higher BMI classification directly proportional to the likelihood of developing perioperative complications? For my specific query, I use the following words, namely, obesity, anesthesia, and risk on PubMed's advanced search engine, which garnered over 369 results, with the one shown in the slide being the top two. I picked number 2 as my journal's article for this afternoon. So for the method of appraisal, I chose to tackle the journal is that of a systematic review, which is, as we know, is a review that summarizes the results of several studies that addresses the clinical question. So in comparing the population of the study in the journal, we have patients who are morbidly obese, as opposed to the case which is classified as obese type 2.
With the exposure, the treatment tests causative or prognostic factors in the journal. It compares the use of general versus regional anesthesia on the background of obese anesthetic care. And as for the case, the use of GA, specifically GA LMA, was done. For the outcome, this is mainly in anticipation of perioperative complications. Considering the many anesthetic risks that accompany an obese patient, same goes for the case where were no perioperative complications, but simply it is pertinent that we discuss the possible remedies in the unforeseen event that there is one. And again, the methodological quality is that of a systematic review. So in appraising validity, we have the following questions. Number one, so were the criteria for inclusion of studies appropriate? The answer is yes, given that these following studies, di mabasa. So, so the answer is yes, given that these following studies met the criteria of the PIOM framework for literature review. Sample size is appropriate, intervention. Systematic review. It's not clear in the picture. So again, the answer is yes, given that these following studies met the criteria of the PEOM framework for literature review. Sample size is appropriate. Intervention falls on the jurisdiction of the clinical question. Outcomes are valid and are supported by the qualitative and quantitative results. Next was the search for eligible studies thorough. The answer is yes. Given that a comprehensive search of the literature is important to ensure that relevant studies, both published and unpublished, are not missed. A thorough search for the published literature should include use of electronic medical databases such as Medline, MBAS, the Cochrane Library, and which was exemplified by the journal. As you can see, these are the excerpts from the journal, which were where multiple literature sources and vast medical databases were cited. Of note are those by Cochrane meta-analysis and some non-English based language databases. The journal in question makes use of publications retrieved by a selective search in PubMed, including current guidelines and recommendations issued by specialist societies as well as expert opinions. So to note a few, we have a prospective multi-center study involving around 500 cases reports the probability of difficult direct laryngoscopy combined with difficult mass ventilations in patients with a BMI of more than 30 kilograms to be significantly increased. Another, we have a meta-analysis by Kong et al. Involving 3,942 patients showed a significant increase in the risk for post-operative desaturation, acute respiratory failure, and cardiac events in those with OSA. For the next question, we have, were the assessments of the studies reproducible? The answer was yes. Namely, authors of systemic reviews decide on many things, which are those that, namely, which studies to include, how valid these studies are, and what data to extract. Under relevant question, you can see that there are multiple papers with the same line of questioning that arrive at a similar outcome, of which are based on three categories we see, namely difficult airway, OSA, and ventilation. Multiple papers with the same topics that address the same outcome based on the data extracted of which such categories are exemplified. In appraising the results, systematic review should also present a summary of the results of the included studies. This is usually presented as a table or a forest plot. For this journal, I chose the table format. So what are the overall results of the review? As you can see, this table summarizes the results in a concise manner, which will be discussed more thoroughly in the next following slides. When discussing precision, we usually look at the point estimate of a treatment effect, and that is the value of relative risk, p-values, as well as possibilities ranging from the worst to the best case scenario. For example, the 95% confident the 95% confidence interval around the relative risk represented by the quantitative presentation of this table. As you can see, among the different literature sources used, there is an average of 95% confidence intervals and a high number of p-values below 0.05, indicating a high value of precision among the results of the many different literature sources. Now, when comparing the quantitative presentation with that of the study outcomes, it is evident that there is little to no heterogeneity between the studies, supported by the fact that, as discussed earlier, the paper was highly meticulous with regards to its inclusion and exclusion criteria when it comes to literature sources used. However, though not stated in the paper itself, this could pose questions regarding publication bias, but as the scope of this paper suggests, it is already beyond the discussion. Seeing as these outcomes are those, yes po daw. Sorry daw. Sorry daw. Homogeneous dapat po. Sorry doc. It is uh, from what I ano po doc, it is evidence that there is little to no heterogeneity po doc. Homogeneous po doc. Yes po. Yes po doc. Yes po doc. Yes po doc. Hinabaan ko sa yung I should have went with homogeneous agad po doc. Yes po doc. Kasi homogeneous po doc. Okay. So, seeing as these outcomes are those used in the current guidelines and our recommendations issued by specialist societies, it is only appropriate to say that the outcomes are applicable to the patient and should be guides for complications that one should anticipate for in the anesthetic care of obese patients. So, in the association of morbid obesity with certain anatomical features and comorbidities that affect outcome require a thorough preoperative assessment of the patient. Patients with abdominal visceral fat distribution and metabolic syndrome have a high risk of comorbidities such as diabetes mellitus, arterial hypertension, atrial fibrillation, and coronary heart disease, which in turn can cause perioperative complications, namely difficult airway, obstructive sleep apnea, and so on. And the severity level of these comorbidities needs to be noted. The anesthetist clinically evaluates the patient during the preoperative assessment, and it is also essential to record their functional status and estimate their physical capacity. BMI is not suitable as a sole criterion for further investigations or special anesthetic techniques. So the perioperative administration, for example, in terms of medications, the preoperative administration of benzodiazepines to adipose patients should be avoided due to the associated risks of apnea. Substances with fewer respiratory depression side effects, such as clonidine, may be considered to relieve anxiety. So it is still disputed for the anesthetic technique in the paper. It is still disputed whether rapid sequence induction with no manual ventilation should be performed in the presence of morbid obesity to reduce the potential risk for aspiration. Even in the absence of clinically apparent heartburn, Although pressure in the abdominal cavity is indeed high from pure functional aspect, the risk for aspiration in obese patients is not generally considered to be higher. However, in the paper, in a large meta-analysis involving 460,984 patients, the prevalence of gastroesophageal reflux was 1.7 times higher in those with a BMI equal to or greater than 30 kilograms per meter squared than in normal weight patients. So, and then as reported by the Valle earlier, use of PEEP is also essential to prevent atelectasis. Also, although excessively high PEEP levels can result in barotrauma and hemodynamic instability. In the paper, a recent meta-analysis concluded that volume-controlled ventilation with a high PEEP level of more than 10 cm H2O intermittent recruitment maneuvers result in improved gas exchange and less pulmonary atelectasis. The patient should not be, and then furthermore, the patient should also not be extubated until they are fully awake and alert, can follow commands precisely and breathe spontaneously and effectively. Residual muscle relaxation should also be excluded beforehand, using relaxometry and antagonize if necessary with appropriate drugs. And lastly, if possible, regional anesthesia techniques are from the paper alone. The consensus is they prefer it over general anesthesia in patients with morbid obesity. Controlled randomized studies dealing with this topic are lacking. However, in many cases, adequate regional anesthesia allows early mobilization and reduces systemic opiate use and its associated side effects. Furthermore, pulmonary problems and difficult intubation with potential complications are also avoided. For the summary, thorough understanding of the pathophysiological changes and comorbidities of morbid obesity and the associated risks are essential. The risk of pulmonary complications such as respiratory failure, hypoxia, and apnea is markedly higher in morbidly obese patients, especially those with asthma. Short-acting, less lipophilic anesthetic drugs are particularly useful as a multimodal pain therapy for the avoidance of high opiate doses. And the indication for intensified post-operative monitoring depends on the patient's pre-existing illnesses, the type of anesthesia, and the type of surgical procedure. And regional anesthetic techniques should be used if possible. More or less from the paper, it's a case-to-case basis depending on the operation that needs to be done on the patient. For the conclusion, the pre, intra, and post-operative care of these patients presents special challenges. The anesthesiologist must be aware of potential comorbidities, specific risks, and pathophysiological changes in order to provide adequate care to this patient group. For the references, it's hard for morbidly obese patients.
Are you ready, Doc?
Okay lang to, 10 slides.
Ay, we?
5 slides. Hello. Good afternoon, doctors. I'm Ryan Pugimo, second year anesthesia resident here to discuss women's recovery after surgery or ERAS. So here are my objectives for suffering. So in major surgery, prolonged hospital stay, and meron po. Meron po. Ayan po. So, discuss lang po. ERAS. So, okay po. Okay po. Sige po. Okay po. So, prolonged hospital stay and increased post-op morbidity following major surgery always been a cause of concern to the attending perioperative physician. So, in major surgery, we have exaggerated stress responses such as pain, paralytic ileus, increased cardiac demand, and respiratory complications, which can cause delayed recovery for the patient. So in recent times, post-op outcome is considered to be positive only when it is associated with a shortened length of hospital stay and the absence of post-op functional incapacitation. So despite all of the recent advances in peri-op patient management, ensuring a positive post-op outcome after major surgery is still a difficult goal to achieve. So ERAS, or the Enhanced Recovery After Surgery, is a protocolized scientific pathway applied to boost the outcome and enhance the recovery phase after surgery. So this encompasses multimodal evidence-based strategies at every step of perioperative care, including the rehabilitation phase. So they have lead to a reduction in complications and hospital stay, improvements in cardiopulmonary function, early return of bowel function, and early resumption of normal activities. So successful implementation of ERAS protocol requires proper coordination between the surgeon, the anesthesiologist, the nursing personnel, the patient, and the people looking after the patient in the perioperative period. So what's the role of an anesthesiologist? So an anesthesiologist plays the most vital role of guiding and monitoring some important elements such as preoperative patient selection and optimization, the choice of anesthetic regimen, fluid and pain management, and thus facilitates and bridges the gap between pre and post-operative care. So flash before you is the ERA society diagram that contains elements within the preoperative, intraoperative, and post-operative period. Hindi po, ma'am. Yung iba-ibang ano na po. Yung ano lang po, in general lang po, ERAS. Hindi na po nasama. Hindi na po nasama. Hindi po nasama. Sorry. ERAS lang po. Yung ERAS. Yes, po, ma'am. Yung yung ano po niya, ma'am, yung marami po kasi siyang guidelines, ma'am. Depende po sa ano. Madami. Most likely po, ma'am. ERAS in general po, ma'am. Ah, Dun po kasi ma'am sa ano, sa didactics wala pong in-specify na ano. Pero wala pong naka-specify na specific na type of guidelines kaya hindi ko na. So lahat po yun, ma'am. Madami mo yun. Tinignan ko po kasi ma'am yung sa website. Isang pong ano. Sorry po. Kay Doc Boyet po. Hindi po ma'am. Hindi po sa hindi po sa inyo. Hindi po. Nasaan po? Hindi po. Okay po. Okay po. Maiksi lang po, ma'am. Next. Yung ano lang po to, ma'am. Pre. Ano? Yun lang po, ma'am, in general lang talaga. Mabilis na po. Yung- Pero nung ano po, ma'am, guideline na may specific pa yung gusto mo. Sorry, ma'am. Okay, ano po, TO po. Ano? Sige, ma'am, i-confirm ko po kay TO. Meron po kasi ma'am, iba-ibang may bariatric, geriatric, obstetric. Ay, sige po. Colorectal, pwede ba? Okay ba? Okay po. Yes, yung eras mismo, ma'am. Tapos sa guidelines po nun. Okay po. Okay po. Thank you po.